views of what works and what doesn't work. And one of the domains we tried to fill as best we could was around equity and health equity. And this is quite a challenging concept, I find personally, and also to understand what kind of evidence might be relevant to include, to inform, to make sure that we make an informed decision. And so today's session really is to kind of bring further up to our awareness, what is health equity? How does it get incorporated in decision making? Understanding where it fits into the evidence to decision process. We have some colleagues that have kindly agreed to share their experiences, either from the guideline group or from other areas of spheres of work around equity and decision making. And I'm hoping to have some more in-depth discussion to try and unpack which kinds of equity considerations might be most important for different contexts and different questions. So that's where we are going today. This community of practice is actually something that we're doing together with you. And so we are very much driven by the topics you want. And if there's anyone who wants to lead a topic in the future, Idris, I think that's also something we'd be very keen to explore. And we will just create this, we'll create the platform for people to do that. So in taking us through the session, we've got our first speaker, so I'm delighted to introduce Omar to the team. And he did put his name into the chat so you can see where he's from, but what you don't know about him is that he's very heavily involved in the health equity research, supporting guideline methods advancements, working with our colleagues, Holger Schunemann, Peter Tugwell, Vivian Welch, and many others. He has a master's in clinical epi, and after that, he's now a medical student at the University of Toronto, but I know he's been working across all different elements of health equity in research and advancing methods. So Omar, you're welcome to say some more about yourself if you'd like to add, but and let's see if you can, are you going to share some slides?
Yep, can you see my screen?
Yeah, absolutely. Yeah, it's perfect from my side. So over to you, and thanks very much for setting the scene for us.
No, and thank you for an amazing introduction. Couldn't have done it better. So as Tamara said, my name is Omar, and today I'm going to be talking to you about equity and guideline development. So just some disclosures here. I am the incoming lead of the GRADE Equity Project Group, part of the GRADE Working Group. Some of the methods that I'm going to be sharing with you today, I've conceptualized myself, and I've also received funding from Public Health Agency of Canada for some of the experiences I'm going to share with you today. I'm also a member of the Cochrane Equity Thematic Group and the Canadian Post-COVID Conditions Equity Oversight Committee. So I'm going to be going over these 5 main points here. First of all, what are health inequities? So how should you define them? How can they be exacerbated or created from guideline recommendations? How do we consider equity in guideline development? And I'm going to share with you our ongoing work on instilling equity in the whole guideline process. So I frequently see this confusion between health inequalities and health inequities. But I think it's important to really understand this part when we're trying to think about equity in guidelines. So according to the WHO, health inequalities are differences in health status or the distribution of health determinants between different population groups. I think about this definition is that it doesn't really consider whether these differences are avoidable or unavoidable. And even if they are potentially avoidable, are they acceptable, or are they really unjust or unacceptable, like they should be addressed? And this is why this definition of health inequities is very accurate and very precise, because here we're looking at inequity as a moral or ethical issue that needs to be addressed. And so the definition proposed by Whitehead, very famous definition, is that health inequities are differences which are unnecessary and avoidable, but in addition are also considered unfair and unjust. So that's very important to keep in mind when we're thinking about inequities. And so inequities are not just caused by poverty and low income. There are so many factors that could contribute to a population being socially disadvantaged. There's a very famous acronym called the Progress Plus acronym and or framework. And it basically, each letter stands for a characteristic that could be associated with health inequities. So the P in progress stands for place of residence, the R, race or culture or language, O, occupation, G, gender or sex, R, religion, E, education, the S, socioeconomic status, which is the income part that we all are familiar with, and then social capital, which means your personal network, and as like, for example, people that are migrants and don't have a network of humans or support would be at a disadvantage. And this would again be avoidable because you can help with their integration better. Very important point is that health inequities are present between and within countries. So if you think about certain conditions, for example, communicable diseases, and I'll come into an example for a second, you can see that, for example, in the West, that's not a big issue, but in Africa, by the way, I am Egyptian. So for example, for us, we have this issue more prevalent. And so there is a resource issue that needs to be addressed and be a cause of inequities there. And even within Canada, we can see here that we have the indigenous communities that live more north of Canada. They have TB as a major issue health-wise. So the infection rate in the indigenous communities is 200 times higher than that for non-indigenous people in Canada. So you can see again, within the country, inequities could exist as well as between countries. And this is where guidelines come in. So they're very important in terms of telling people what to do in specific situations, and they are developed usually based off of prioritization of the conditions according to the setting that is going to be implemented. And so when guideline developers just focus on the effectiveness of interventions, you end up potentially applying guideline recommendations that are prioritized in one setting incorrectly in another setting. And so an example here is, again, applying guideline recommendations, prioritizing the treatment of non-communicable diseases in Africa, where communicable diseases are the major burden of disease, and that would result in increasing inequities. So when you're trying to develop guidelines that are potentially going to span over multiple countries, multiple regions, you need to really think about what is the major issue in different settings, not just within the setting that you're in. Another example is, for example, in the Philippines. So undernutrition is preeminent in rural settings, and you can see here 36.8 in rural settings compared to urban. So but overweight issue is more prevalent in urban compared to rural. So if you're going to develop a guideline recommendations, you need to think about different regions and focus your guideline recommendations accordingly. Yeah, and so as I've said, there's a lot of guideline organizations that have recognized equity as a major component that the guidelines that they need to address, so they can help reduce these disparities between regions and countries. And there have been multiple approaches, try to put in equity as a minor focus of the guideline compared to a major focus. So a major focus of equity in a guideline would be developing a whole guideline focused on disadvantaged population. Like, for example, here in the West, homelessness is a very major issue. So a guideline focused on homeless populations or people experiencing homelessness would be a major focus of equity, while a minor focus would be a more generic guideline that has a section dedicated to disadvantaged populations, such as guidelines on maternal health. You could have a part of the guidelines focused on women with low income. And so I'm pretty sure most of you are familiar with the GRADE organization and the framework that they have for developing recommendations. And so they also have the evidence to decision framework, which has around 12 criteria, depending on what kind of recommendation you're developing. But one of those criteria is the impact on health equity. And so this is what it looks like here. You can see that this is the question usually in the ETD. What is the impact on health equity? You have to make a judgment whether it would be decreased, increased, or you are uncertain. And this is one way to explicitly consider equity in the guideline development. Another thing that has been developed by the Grade Equity Working Group is that they've identified 9 areas where equity would be considered in the guideline development process in general. So that includes setting priorities, guideline group membership, identifying target audience, generating the guideline question, and so many other steps. They've also developed some guidance on how to assess the certainty of evidence for equity populations. And they've considered these 5 criteria that you should think about when assessing the certainty of evidence. And in fact, there's also another piece of guidance from the Grade Equity Group where they have said, we know what equity is not just relevant to one criterion of the ETD. In fact, it could be relevant across all of them. And so this is very useful when, let's say, you don't have the evidence or the infrastructure to really, the resources to just answer that equity question. You could really think about equity as you go through the whole ETD, like through the is a health problem a priority, the benefits and the harms, as well as the importance of the outcomes. Maybe some populations might value the outcomes differently. Resource use, are there any cost effectiveness issues or resource requirements required in certain conditions? And this could help you think about equity as you're going through the process. And regarding the equity criterion, recently I've developed this approach that's kind of like a minimum, what are the minimum steps needed to answer this question if you just want to focus on the impact on health equity question. And this was trialed on a cannabis guideline. And so it basically builds off of the original ETD guidance, but it has some extra elements. And what's really good about this approach, and I'm going to say, you don't really need to do an individual review or seek additional resources. You can just use the evidence that you're using for your general guidelines to identify these elements. And so basically, you identify this. I'll just take you through it quickly. Identify disadvantaged populations, usually through discussion with your content experts, looking at the data that you have. Seeing if there's any differences in baseline risk, looking if there are any populations that are not represented properly within these studies, then assessing the analyses and assessing their credibility, and thinking about any implementation barriers for the intervention that you're going to propose across the populations that you identified initially, and then try to suggest implementation strategies. I'm kind of rushing through it, but we can talk about it more if you're interested. And one of the ongoing efforts that we have right now, this is a very big table, but basically what I'm trying to show you here is that we're thinking about how can you consider equity throughout the whole guideline development process, not just 9 steps that were identified by the Grade Equity. And so we're almost at the end here, but really what we're seeing right now, we've deployed a survey and looked at the evidence, the guidance from guideline handbooks. And what we're realizing, it's really important to try to think about equity really from the start, from the organization, budget planning. So how much money will you need? Who do you need to recruit? Trying to recruit equity experts. They can help you throughout the process. And so I just want to focus on, I just want to give you one take-home point. Equity is difficult, as Tamara said, and it's really going to be different depending on where you are and how you really look at equity and define equity. So what's really important is to be transparent and explicit in your approach, and just think about fairness. That's your main signaling question when you're trying to answer any question about equity. Thank you for your time. And here are the resources. I'm going to share them with you guys, and hopefully you find them useful.
Thank Thank you, Omar. You can join me in showing our appreciation. Thanks so much for that whirlwind tour. I realized we didn't give you enough time to share because there's a lot of depth in those concepts, and you did incredibly well. And we might have to come back to some of your slides as we progress with the conversation. But I will, since you've kind of given us the landscape of how equity is considered and really underpinned that it's a mindset in a way, because it's cross-cutting. It's in everything that we do with the guideline process or decision making. I just wondered if we could open up and see if there are any questions or clarifications before we move on with the session, knowing that Omar is staying on. But let me just check for any hands at the moment or questions in the chat. And welcome to everyone who's joined. So thanks for that, Omar. So don't go anywhere. Keep your slides at hand, and those resources look excellent. What I would like to do is to ask, one of the things, so we've done the, guideline processes in South Africa, Nigeria, and Malawi in the child health field. And we've tackled and done our best to try and address and make sure that equity was in the forefront. But with the focus on that domain within the guideline decision process, trying to fill that in with contextual evidence. So that's been a good process, but we've got a few colleagues on the line, and so I'm going to come to our colleagues from, maybe I can start with our colleague from, we've got Dr. Isa Abdul Kadir from Nigeria, who's a professor of pediatrics, and he was involved with the Nigeria, the guideline decision making in Nigeria, and where they looked at two main areas. One was around enteral feeding, and the other was around hand hygiene, all in the newborn space. So I wonder if Prof. Isa is here, if you're able to unmute. I'm just checking.
Hello, everyone.
Hello.
Yes,
greetings. Welcome. Oh, fantastic. Yes, we can hear you. Good.
Thank you for having me. Unfortunately, my network isn't so good. But thank you very much. I think I align with most of the things that were said by the first presenter. And now, one of the issues, we had a very robust discussion during the guideline development meeting. One of the issues we had, were, like you said, issues of equity are usually contextual. And some of the study we had really did not look at evidence for equity. So most of the things that were mentioned by the first speaker, we actually experienced them. But the other thing that was quite glaring was even with the evidence we had, there were challenges looking at the members discussing the issues. Now, the major issue they were looking at is, of course, we know that this is a problem. Now, should we negate the evidence because of the fear of widening equity? For example, people thought that having training on hand washing was something that was going to be positive in trying to prevent infection and improving outcome. But at the background, they also thought already there's a gap and some people are disadvantaged, and their problem was that they could not get this training. So those who discussed and were looking at the guideline thought and got a bit confused. Now recommending for more training when already a lot of people could not have training, and already we are feeling disenchanted or disadvantaged. How do you go about looking at that? So if I could say the summary of the issues raised were that, should we negate evidence for fear of widening equity, or the other approach, should we uphold and look at the differential ways of strengthening such recommendations, knowing fully well that perhaps they also have background knowledge that this recommendations are still going to be met, but challenges to implement them. And so that was a bit of confusion for most of the people who were engaged in that. So it's I think that was quite blurring and eye-opening. This is something we thought was going to be straightforward, but looking at it from the background of the context, there was a bit of confusion. So I thought that was something I could share with you. Thank you very much.
No, I think that sounds fantastic. So if I understand correctly, thank you, Professor. And I'll come to Arthur next, but just to underline some of what Isa was saying, if I've understood, it's that there were issues of access and implementation. And so the equity considerations help to think about other criteria around feasibility, implementation. So I hope I've got that right, but that sounds like a very interesting conversation. Omar, what do you think?
No, thank you for sharing that experience. And I think that's something that we also have experienced within the Canadian post-COVID condition guidelines. So first of all, this guideline is on people with long COVID, and there's little to no evidence on long COVID. So almost all the recommendations have been developed using indirect evidence on COVID studies. And when it came, so equity is a very big focus within this project. And so we have a very interesting, it's a brand new thing, and it's going to be included also as part of the new consensus guidance for equity, is the Equity Oversight Committee. And I think it has been extremely beneficial to the guideline project. We're a group of 12 individuals, a mixture of patient representatives, guideline developers, people with expertise in equity, and equity researchers. And what we do is whatever the guideline panel produces, we take it and we critique it from an equity perspective. So if we get an evidence to decision framework, we really focus on, was equity considered throughout the deliberation of the evidence, or like seeking the evidence and how the evidence is being formatted. What are the equity considerations that we can think of? Because as you can, like in evidence decision process, you have your two columns. You have research evidence and you have additional considerations. This has opened up the space for things that come up through discussion of the panel members, as well as evidence. And sometimes you don't have the evidence. And so in this situation, when we talk about issues of access, issues of cost, I agree, they're usually not reflected in the evidence, but they come up through discussion. Now, when they come up, I think that we have to make a decision on how much will this affect the strength of the recommendation that we are developing. So if the majority of people that are going to be using this guideline recommendation are not going to have access to it, then I wouldn't publish this as a strong recommendation, even if the benefits are very, very high compared to the harms, of course. So that's why equity is part of the guideline, is part of the evidence decision process. It's one factor, so we don't want to scare people by saying it should be more important than the other ones, but at the same time, it is important and should be thought about, again, transparently and explicitly. And once you write your thoughts down or seek the evidence, you will realize that you will be able to weigh how much it should carry.
That's a great point.
Yeah,
great point. Thanks, Omar. Go for it.
No,
you've got another thought.
Just last point. No, just last point. And we were thinking, this is one thing that also came up. Like, what is the scope of the guideline? Do we want to influence policy as well? Should the guideline have policy recommendations? And I think that's something that maybe we can look into. Like, if you are realizing there's issues in access, like fundamental human resources or things, maybe a guideline should explicitly state you need to provide X and Y and Z to certain populations, again based off of your expertise and based off of your search of evidence.
Yeah, the specifics to support implementation and addressing equity issues. Thank you for that. Thanks for that. So in moving on, I wanted to see if we could gather some other inputs. So I wanted to ask our colleague from Malawi, who's they were tackling an enteral feeding and nutrition-related topic, actually similar to the one in Nigeria. So I'm checking, Arthur Bunyani, are you here with us, sir?
Yes, Tamara, I'm around.
Okay, fantastic. And if you wouldn't, I mean, we're just interested in reflections for a couple of minutes, and I also invite others to reflect back. So, and then Louis, I hope you're here, and we'll chat in a bit. But Arthur, over to you.
All right, thank you, Tamara. I think Omar has almost exhausted whatever I had. I think on our reflection in Malawi, I think we are doing enteral nutrition initiation in children. So I think what Omar has presented mainly has just given me some insights on when we're doing this evidence to decision making process, when we're coming up with these recommendations. Yeah, so really the issue of equity, right? Like what he emphasized much is on his comment about the evidence. We couldn't find evidence locally, so we're using secondary data to support, right? And the other issues were like just opened my mind when he was presenting, right? Not all the patients will require to be started on EN, because some are catabolic, some are critically ill, so you may just worsen their condition. So this issue of wicked, I think, and we're also thinking of having some policy influence with this guideline recommendation. But there are issues of who take the task. We don't have enough dietitians on the ground to do that. So I think it's really nice to go through this meeting. We're having some more insights how we can also go about some specifics when we're implementing our recommendations from whatever we're doing in Malawi in nutrition implementation in the children in Malawi. Yeah, basically, I think that's what I had. But Omar has almost exhausted whatever I had. I think that similar issues of evidence, issues of policy influence. That's what we're thinking around about equity and how we can provide this one. If we have got the recommendations, will they be able to apply our evidence in the hospitals? So those kind of issues around. Yeah.
Arthur, thanks so much for that reflection. And in a way, it's good that we hadn't gone in depth with the training on equity before, and we just went straight into our guideline process. But the fact that what Omar was talking about resonates is a good sign that we, sometimes we don't have all the words, social capital doesn't spring into my mind generally. But, now that you've shared those thoughts and inputs, it does resonate with us, Omar, so that's helpful. And Arthur, I think in your field in nutrition, there's so much that's equity related, really. There's so much inequity and food security in our region, etc. So really good to hear your reflections. And I'm going to ask, so we're very lucky also to have Louis Reynolds here. So Louis, if you're welcome to be screen on or screen off as others. So Louis is representing People's Health Movement. And maybe, Lou, you can introduce what PHM is about, but People's Health Movement is one of our partners in the project.
Thanks, Tamara. The People's Health Movement is a global movement, mainly active in the global south and concerned with the issue of the right to health. We believe that health is a fundamental human right, not just health care, but health, the highest attainable state of health. I'm also a pediatrician, retired. And in my retirement, I remain active around trying to promote health for all. So when I'm talking about equity, I've only got one slide, which I'll bring up in a minute. I'm going to look at it in sort of two broad areas. One is in terms of health services. The second in terms of the social determinants of health. So to start with, and then I want to look at, dig below that a little bit and look at the issue of whether guideline development should take policy into account, which is what Omar asked earlier, or mentioned as a possible thing to open up a discussion about. So when it comes to big pardon, sorry.
Go for it, and you're welcome to share your slide anytime.
So when you look at equity, it's a fundamental part of the global project towards universal health. It's called universal health coverage. The discourse has shifted from universal health care to universal health coverage. And I think that's a very important thing, because it's kind of happening secretly or surreptitiously. And to me, what that means is universal health care is in most of the world's human rights instruments, particularly the right to social economic determinants of health, rights to health, I mean. So the shift to coverage implies a shift to insurance-based models. So you're covered if you have an insurance scheme, but they don't provide equitable care. And there's no way of providing equitable health care if you have a fragmented health system, particularly if the market plays a big role. And I'll move on to that in a minute. So going on to, in the 70s, Tudor Hart described something he called the inverse care law. I'll put a
We see the link, but now you are muted, Louis.
Sorry, where was I? So I put a link to the inverse care law, a global perspective on it in the chat. It operates mainly where the market plays a big role in healthcare delivery. And I think that applies in most countries around the world, except, I suppose, Cuba and so on. But I think it's tied up to this thing about insurance versus the right, the coverage versus the right to healthcare. So moving on to the social determinants, this is where I want to bring up my slide. Let me see, can I share?
Yeah, you should be able to.
How do I do this?
There's on the top right next to on mine where it says leave, don't click leave, but there's a little button next to it that's got an up arrow and it says share. Is it the same for you?
Yep. So let me find.
Interesting paper.
What's that?
Interesting paper.
So can you see my slide?
I'm looking. Not yet. Can others see it?
Not yet.
Okay.
Share screen. Oh, this screen, yeah.
And then you have to click on a screen. There we go. Something's coming. Okay, we've got it.
You got it.
It's not full screen yet, but okay, now you're doing it.
Okay, so this is an old, long-term scheme. We were talking earlier about malnutrition. So, for example, if you take malnutrition, to promote equity in malnutrition for children, you have to look at the causes, those immediate causes, which are nutrition specific and operate at the household. And below that, you have the underlying causes, which are food insecurity, which is a big issue in most countries and more in the global south. Inadequate healthcare systems, unhealthy household environments, and then poverty and unemployment and so on. So those are the underlying causes. And then you get down to the basic causes. And this is where you enter the area of the political economy of health.
Mm.
And this is about distribution of resources and the power over the distribution of resources. Now, if you look down this scheme, you'll see that inequity applies at every level. So I'm just sort of giving you some contextual thoughts.
Brilliant.
So the other question is, who delivers the care that you're developing guidelines for? Is it doctors, nurses, community health workers, teams of all of the above? And where, in which geographic areas? Are these geographic areas more vulnerable than others? For example, in the province of KwaZulu-Natal in South Africa, about 2 or 3 years ago, there was a huge flood. And many people were cut off from their nearest clinics, from their supplies of medicine, from their caregivers, because the roads were washed away, and even some of the health facilities were destroyed. And in those sort of situations, you need a strong community-based health system. And this is going to get worse with climate change. Finally, getting back to the political economy, I think when you're talking about equity, you're really talking about justice. And the aim of, in my view, the aim of equity is to achieve justice. And justice, when you're talking about justice, you're talking about politics, and you're talking about economics, and you're talking about policy. So I think I'll end there, and maybe we can discuss later.
That's powerful, Louis, to think about that. That, you know, equity being justice, and how we make sense of that. So I think you can probably unshare now, because I'm seeing my face double.
I've unshared.
Okay, so I'm not sure whose screen it might be. Okay, maybe Idris, you can help us try and
it's still my
solve
screen,
that.
I don't know. I've stopped sharing. Oh, sorry, hang on.
Okay.
I've stopped sharing.
Okay.
Yes, yeah, he has stopped sharing now.
Okay, all good. But yeah, those are great concepts and thoughts. And I think, so thanks, Louis, thanks, Issa, thanks, Arthur, for your experiences. And, you know, this is also a chance for anyone in the room, if you want to respond to anything that's been raised now, if you want to agree, please use the chat or raise your hands and just be part of the conversation. We're all just trying to unpack what is clearly, you know, as Louis just shown us, it's a massively complex topic. And yet we're juggling it amongst all these other criteria. Does this intervention work? How much does it cost? Is it affordable? Is it equitable? Will introducing it reduce equity, along with acceptability, feasibility, and all these other factors we're trying to hold in our minds when making informed decisions? So Sumanth, yeah, jump in, and then I'm going to ask Nandi to, I'm going to introduce Nandi, and then she'll have a chance to speak to her.
Thanks, Tamara. Hi, Omar. Excellent presentation. Thanks for bringing up this equity discussion in Gela. My PhD topic was related to equity-oriented research priority setting in Malaysia. The Malaysian Oral Health Division for Ministry of Health does the priority setting in a traditional way. So I did equity-oriented research priority setting, and the research questions what I got in my project were totally new and quite specific for ethnic groups. And when I presented my findings to the Oral Health Division, the question I was repeatedly asked was, our budget is limited, and how do we concentrate on the research priorities of minority ethnic groups, because we have to take care of the majority ethnic groups' priorities. So that was a question repeatedly I got. I tried to convince them, saying that the majority of the health inequalities are because of these minority groups, and if we have to address these inequalities, we have to look into those priorities raised by these ethnic groups. Somehow, maybe I was not good enough to convince them, or I'm not sure. How can I answer such questions? How can I convince policymakers to take up those specific research priorities which are important for minority ethnic groups? Any suggestions, Omar?
Yeah, or maybe to all of our speakers, because we have a lot of people who are senior policymakers and in other roles in their countries. You know, how do you make sure that equity is a key driver of, and, you know, informs where you invest and where you put your money? And Omar, you're welcome to respond as well, but just checking if there's anyone else here. Sumant, great question. Yeah, Omar, let's go on with the conversation.
That's a very interesting experience. Honestly, I haven't been in such a position, but I have been with policymakers, like decision makers at the ministry level. But I have worked with people that, let's say, they're afraid. People are generally afraid to try things that they're not familiar with. It's a common theme across all partners. I find that usually when you want to convince someone to do something, it's important to talk in the language that they find important. So when I think of policymakers at a government level, usually it's all about reducing costs. Now, if there's evidence from an evidence perspective, does reducing inequities, reducing costs, it's not always straightforward like that, right? But I do think that generally, I think you said that as well, like the majority of the disease burden is caused by populations experiencing inequities. So when you address these populations specifically, you will reduce the total burden of the disease, which will have longer benefits, the long-term benefits on the healthcare system of the country. I think also, just one more thing. Like, I think equity doesn't have to. Let's say you said that you had different questions. I'm not sure if it was overlap or was it a completely different direction. But when I think of equity, sometimes you don't have the resources or the ability to really tackle it completely head on. Sometimes it becomes a sub project, or you could say like a subset of your whole effort. So if you had identified, let's say, 3 populations that were experiencing the highest disease of the highest burden of disease, maybe those populations could be, how can I say, within the scope of the government's priority setting, or have some certain, we talked about some considerations that could focus on them without really completely deviating from the government policy.
Thanks, Omar.
Thanks, Omar.
Thanks, Sumant. Yeah, and I think colleagues, I mean, I think there are a lot of, I'm looking forward to introducing Nandi, because one of the things I'm asking everyone here in the group, so Nandi, feel free to put up a slide, but while you do that, I want to ask everyone here to respond to the question, in your country and your context, do you experience, you can put it into the chat, yes or no, do you experience that at the policy level, the guideline level, that people are adding more and more and more interventions? Do you find that they are adding, I guess the question is in the context of, maybe the clearer question would be, in your context, do people disinvest and reduce the number of interventions that are being recommended? How much disinvestment do you see? Do you see disinvestment at your national government levels, or even at your in your context? So if you can use the chat, because feel free to use the chat now. So the question is whether people disinvest. Do people stop interventions that are do they reduce the number of strategies and interventions?
Sorry, Tamara, before people respond, there's a comment here that Nandi has made quite a while. I don't want it to just
but
drown.
Idris,
Just
I'm
leave it
about
to her
to.
Okay.
Idris, I'm going to introduce Nandi soon, and she's going to speak to it.
Okay,
So,
no problem.
Yeah, all good. Thanks. No, so I do want. So, have you experienced disinvestment in your context, where people stop doing something? Maybe it's a very difficult question, but I was thinking of it in the context of Sumant saying, you know, there isn't much focus on different equity issues. There's such a focus on adding every new effective intervention that we don't see a lot of disinvestment. We see a lot of additional load in environments. But I'm a bit worried that my question was so unclear that I only had 3 responses. So maybe it is time to give up on that one and move on. And I think what I will do, thanks Sumant, thanks Omar for adding in there. So we are so fortunate to have my colleague Nandi Siegfried here, my colleague and mentor, and she's a chief specialist scientist at the South African Medical Research Council. She's been involved with dozens of a variety of WHO guidelines as the methodologist, as the methods have evolved in that space, and is a public health specialist. So some of the topics are very complex topics, and Nandi, you can probably introduce what some of those are. And there was some more information of Nandi's bio in the flyer that went out, but she's an extraordinary clinical epidemiologist, public health specialist, and I'm delighted that you can share a little bit of your experiences with how you've navigated specifically equity in some of the complex decisions. Thanks, Nandi.
Thanks, Tamara, for that very generous introduction. So, hi, everyone. It's very nice to be with you all today. Tamara, I was thinking, looking at the time, we certainly aren't going to have as much time as we'd hoped for this. But what I'm going to suggest is that I present the case study and then hand over to you. And then perhaps just in the last 5 minutes, if we push it through to 10 to the hour, I can just summarize those last 5 slides around the what, why, if, etc. Yeah.
Sounds good.
Okay, so do you want me to share my slides? Does that mean I lose my screen? I'm just on a single screen. Let me see.
I'm happy to.
Right.
You can.
Yeah, I thought it was being done on the other side. So let's see. That's all of you. And now?
Yes, we can see.
Great. The new teams can show me all of your faces on one screen too. Okay, so just to say that since 2008, when I conducted a Cochrane review, which then inputted it into WHO guidelines, I've been working with various departments across WHO, developing guidelines, all based on the GRADE framework, because WHO uses that in terms of formulating its guidelines. I will say that perhaps something which is perhaps a little bit different to if you're doing guideline development within clinical associations or at a country level is that by definition, WHO has signed up to the underlying universal human rights and non-discrimination, equity, etc. So you already have a focus, even before you start, that the guidelines and the process themselves have to be representative. They have to consider equity throughout. But I was very interested, I think it was Sumant who was talking about equity and priority setting, because I think that's really the first step in the process. So what we thought today, I'd do today, and what Tamara asked me to do, was just take you through a case study and try and consider Progress Plus, those equity principles or those equity domains, when thinking through what was done in these WHO guidelines. And to be frank, if I think of the work that I've done, which has mostly been in the HIV, TB, and in the nutritional field, there always has been a strong focus on equity. But this particular case study I thought was interesting because it looks at self-care interventions for health and well-being. And I thought it was interesting in the way that equity was actually brought into this guideline. Okay, so I'm struggling to move this on. I'll have to go down here. Okay, so I thought we'd focus on this PICO question, which is, should emergency contraceptive pills be made
Mandy,
available?
Oops, it wasn't showing,
pardon?
but now it is. It's showing now.
Thank
It
you.
just wasn't yet. Okay.
Okay, so should emergency contraception be made available without a clinician's prescription? So I'm not going to go through the PICO in any particular detail, but you can see there that the intervention itself is getting the emergency contraception over the counter or from a pharmacist. But the key thing is it's without a prescription. And there were all the outcomes you can see. And I think it's interesting if you look at outcome 6, you can see already within this guideline process, the aspects surrounding human rights and equity were already being considered in terms of looking at the evidence, the effectiveness, evidence synthesis, and the outcomes that would be used in that. Okay, so has it moved on, Tamara?
It is it's lagging. It's not moved on yet. Do you want me to share from my side?
I don't think it's I think it's because it's on the presentation mode.
It's moved on here. I don't know why.
Oh, okay.
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 All right.
Oh, now I see it.
I can
Okay.
see it. I think it comes slower to your side, Tamara.
Oh, okay, good. I'm further away. Okay.
Okay, so this is something that I'm sure everybody on the call is familiar with, a typical grade ETD framework. And I thought I would just briefly talk about the types of evidence that you would want to collect for the different domains. So we know when we consider the balance of benefits versus harms, that's going to be RCTs wherever possible, observational studies in certain situations, and that is when we are considering the effectiveness. So here we want to see a systematic review of the evidence. The certainty of the evidence we derive from going through the grade evaluation. Now, values and preferences, which I think you probably have had a whole community of practice discussion around that already, because it's something that is not as clear-cut as it appears at first sight. But for this particular guideline, we were looking at qualitative studies of women who wish not to be pregnant. The resource requirements were using costing studies of models of delivery, and cost effectiveness, also looking at modeling comparative effectiveness studies. Before I go to equity, you'd look at acceptability, was also qualitative studies and surveys, and with feasibility, it would have been looking at observational evidence and programmatic experience. So when we talk about equity using the grade ETD framework, we need to think about what type of evidence we would want to gather, so what, and how we would gather that evidence, and what, of course, would be feasible within your time constraints. And I think it was Omar who mentioned earlier that it might not be that you have to go and do particular equity-focused additional studies or even evidence synthesis. You might find that information, and I'll be presenting some examples of that, related to a priori, predefined populations within your evidence synthesis of effectiveness itself, if you determine that those are priority populations for looking at equity. Okay, so these are some broad questions, and I'm hoping it's moving on. If we think about equity, who is most affected? Are there gatekeepers to access? Who pays for it? Bringing in some of what Louis Reynolds was saying. And are there consequences of inaction? If we don't do something, what could happen? And I try to think about these questions using the Progress Plus domains around burden, sex, gender, ethnicity, and age when it comes to who is most effective. If they're gatekeepers, is it occupation? Is it education? Is it religious, socioeconomic status? Who pays? Again, socioeconomic status comes in there, something you need to think about, as well as place of residence. And all of these, I think, speak to what Omar was presenting. And then with consequences of inaction, and there's social capital put in there. I'm I wasn't really sure how best to capture it, but I think social capital, if you don't do things, what will happen to the community? What will happen to those underlying principles that tie individuals to a group and to their communities and indeed to a country? Okay, so let's have a look at this particular guideline. When it came to age and sex, part of the evidence presented to the GDG included this. 2 of the studies, and interestingly, some of these were RCTs, identified significant decreases among younger age groups, a decrease of 1.6 per 1,000 women in terms of abortion, aged 18 to 19, so specifically looking at young, vulnerable women. And you can see for the 15 to 19-year-old group. So 2 studies actually looked at that. And the GDG noticed that given the unique barriers faced by younger women accessing prescription-only emergency contraception in many settings, it may be that increased access to over-the-counter EC has unique benefits for younger women. So here we see how age and sex come through. When it comes to religion and culture, in terms of the evidence presented to GDG, there was a statement that this was because the availability of EC might remove the need to see a health worker or get third-party permission, e.g. from a parent, partner, or spouse. Attention to context is important, especially as in some countries it might not be sold to unmarried individuals or be readily available over the counter, but rather behind the counter. Tamara, can I just check that it is all moving on?
Idris, yes, it looks like it is, but Idris is your better source.
Yes, it is. It is
Okay.
moving.
Okay, so again here, this sort of slightly, to me anyway, woolly concept of social capital, and that's only because I haven't immersed myself in it, I guess, for as long as I have in other things, and I really thought choice came into social capital. And I thought this was interesting. In many settings, over-the-counter EC is offered as one of an array of options. One study included in the effectiveness review used a blended modality. Women could choose whether to obtain EC from a health worker. This study found no difference between groups and an overall high level of knowledge of emergency contraception use, although pharmacy access resulted in higher use and satisfaction. Given this and the findings about the effectiveness of OTC EC, blended delivery modalities in which users can choose where and how to access it may be most responsive to a range of user preferences. And then finally, this is perhaps not quite equity, but I thought it was important to bring in around access and confidentiality. So if you can just look at from the middle of that paragraph, end users broadly supported over-the-counter EC because they thought it offered improved access, availability, convenience, more flexible hours. Sex doesn't only happen during the week. Confidentiality, privacy, anonymity, and reduced cost. End users also anticipated that over-the-counter delivery would offer less opportunity for judgment from a health worker and greater control for women. So when it came to finally making those judgments across all of the grade domains, I might just stop for a moment and ask what you think the GDG would have said with regard to equity. This is from a guideline which was done in 2022, so we do know what the judgment was. I'm just going to move out of end show so I can see all of you. So what do you think people thought about whether or not the GDG said it improved equity, or what indeed do you think about whether it improves equity or not? Perhaps you can type in the chat. Another option. No, we don't have a green check. Only Omar, who probably should have been excluded from making this determination. Anybody else want to say whether or not, or maybe make a verbal contribution about whether or not you think that offering over-the-counter emergency contraception would improve equity? Thank you. I see definitely improves. Yes, improved. Yes, it seems to me that the NHI, this is in South Africa, for our other colleagues, the National Health Insurance might open up space for guideline development. Okay, significantly improves. Yes, absolutely. So I'll just pop back to the slides for a moment. Unless you were seeing them all the time. Just needed to go out of it. Yes, the GDG said that equity would definitely increase, given all the previous determinations. Just trying to see how I can get back into that mode. Here we go. And perhaps just to almost finish off, I wanted to show you that not only did they make a strong recommendation based on moderate certainty evidence in favor of making it available over the counter, they actually wrote about it in the rationale. The GDG agreed that this intervention was likely to increase access, reduce discrimination, and support human rights, especially among adolescent girls and young women, and among individuals of diverse sexual orientation and gender identity, and that's something we didn't discuss, but is relevant to an expression. And this was because the availability of EC might remove the need to see a health worker and or get third-party permission. So I'm going to just outline before I hand over to Tamara, and we'll go through these about approaches that I've used and developed over time. I'm very much looking forward to GRADE publishing its extension for equity to help us a little bit more concretely and operationalize this within the GRADE framework. But first of all, we need to ask, is it a priority in the guidelines? I mean, you could argue yes, but it might not always be, and that's a discussion we're going to have. Which of your PICO questions require equity evidence? Are there specific equity domains which should be prioritized for the evidence synthesis? What types of studies are required to bring equity? Whoops, I've done something. Are you still seeing my slides or not?
No, we're seeing us.
Okay. I'm just trying to make you smaller. There we go.
Oh, there it is. There it is.
What type of studies are required to bring equity into the ETD discussions and recommendation formulation? And are there known research gaps in the equity landscape?
Great questions. Yeah.
But just before I hand over to Tamara, I think Irma also touched on this. Sometimes you can actually foreground equity as a key priority for the guidelines, which is what the self-care guidelines actually did. They said throughout the development process for this guideline and during the in-person GDG meeting, human rights and issues of equity were emphasized as integral components of both the development and the delivery of self-care interventions. So Tamara, I'm going to hand back to you at this stage because you want to share your particular slides.
Well, I think, Nandi, if I'm not mistaken.
Because you said you had another one that you wanted to put in.
Okay, hang on. All righty. Let me just get to, oops, not that. So I think we can just, so Nandi, this feels like I'm jumping ahead here, but I mean, you asked some important questions about where equity sits, and I'm not sure if anyone has any specific questions for Nandi at this point. We will go back and forth a little bit between Nandi and I, and with you, hopefully. What are your impressions so far? What do you think? Where does how is this sitting? Are there questions that are coming up for you? And I'm going to ask Idris because now the way I've set my screen up, I can't see anything but my slide. Can you see the slide?
I can.
Okay. But just let me know if there are any hands. Yeah, Louis, jump in. That would be great.
I just want to comment on Andy's not necessarily question, but I think that the that your project will improve.
Mm.
I think equity and human rights, I don't know why there is the tick there. I mean, I don't understand this table, I'm afraid.
This is
know,
the
if you think
table that
of
Tamara is
the-
going to walk through now.
Well, it struck me, if we think of the Convention on the Rights of the Child.
Louis, if I can interrupt,
yeah.
the plan is that for everybody to work through this together.
Okay, fine.
But I think you're already making the point that in the context of child health, it's very hard to to say, well, this is not an equity or human rights issue. And maybe it is in the context of, these are the different domains here that you might have in a guideline. So how effective is the intervention? For example, the top one is around health worker related interventions for hand hygiene, which was the topic that the Nigerian colleagues undertook in infection prevention control in neonatal ICUs. And the question is, with limited resources, with with a lot of evidence to try and gather, which which of these do you need to make sure that you are allocating enough resources, making sure you find enough evidence? When is the evidence of a discussion with a multidisciplinary panel with people who are practitioners, implementers, civil society? If you have that panel, is that sufficient? Do you need to be gathering evidence, doing qualitative studies, etc.? So I think these are two interesting questions. The top one is around the hand hygiene intervention, and the one below was undertaken in South Africa, which was on home visits. Lay health worker delivered home visits for preterm and low birth weight infants. And maybe if we just look at the one on the top on the hand hygiene. So I think across the board, we want to know, does something work or not work? What is the evidence of effectiveness? That is a starting point. But even in the context of having uncertain evidence or, not having a lot of evidence in that space, there could be other factors that are important, but that is a starting point. For hand hygiene, and maybe we can focus on these. Yeah, I mean, are there any? Yeah, I'm trying to think how to put this across. And I need to be able to see my screen somehow, but I can't. I guess, are there any elements of difference between these two guideline questions? Are there any that you would think would have more or less importance to kind of gather the equity and human rights information? How much of a equity, human rights, how would you see equity and human rights being important in the hand hygiene space? Or if other people maybe want to think about home visits and lay health workers in the community, equity and human rights. I don't know if anyone has any, how would you see it? And if you were running a guideline process or participating in one, I don't know if you have any reflections on how equity is important on the scale, like on the level of importance it might have for these questions. I'm going to check. I'm going to wait for a hand or some input. Somehow need to make this smaller. Louis, go for it.
Let me try this. I'm not a guideline developer. I'm more of a health activist.
Yes.
So let's look along here. We've got equity and human rights. So we've got what? Emergency contraception, and we've got hand washing.
Hand washing and hand hygiene and home visits.
And home visits, okay. So all of these things have got I mean, equity is extremely fundamental. How can you wash your hands if you don't have running water? For example, if which is a human right, and many people don't have. I think the issue of emergency contraception when it comes to children, they have rights to make up their own minds about things. And this is a political issue because, you know, conservative groups and some churches are going to object to making emergency contraception available over the counter. And so it's politics again and policy. Feasibility and acceptability. Well, you know, emergency contraception will probably not be acceptable to many of the groups in society, and they're going to, you know, I don't know how you deal with that in guideline development, but I would imagine that you have to, how do you improve hand hygiene in places where people don't have running water? You know, those questions.
Yeah, absolutely. Thanks for getting us started on that. Nandi, did you want to add in there?
Yeah, I mean, I think that that's valid, and you could then argue that we would have that as an underlying principle, and I think that that is fine. But in terms of the grade framework, we were really asking, do you need to go and actively look for this evidence? Is this something that you need to think about in terms of different populations, those people who may be more vulnerable, et cetera, et cetera? And so I think this slide is really about asking, what type of evidence would you go and look for? How would you do it? Would you do a whole evidence synthesis, or would you just look within your effectiveness synthesis and see if you can pull out some of those issues? Tamara, I see that there's a hand up.
Lou,
that's
go for it.
Okay.
Well, apologies, it's me again. This is the last thing.
No, you're welcome.
You know, there's some things that you know them. You know that some people don't have running water. Why do you need evidence for that? You know that community health workers, for example, actually, there's a lot of evidence around community health workers, and it's very contradictory. But so I mean, there's stuff that you know that trying to find evidence will just delay the whole thing, you know. In my view. But I'll stop there. I can go.
So, I mean, this really isn't asking that question so broadly. It's really saying, what are the equity issues around this? Do we see if it has an effect on the actual effectiveness of an intervention, and interrogate it more in that way? Because although it seems obvious, because of the work that you're in terms of trying to influence policymakers and so on, it sometimes can be really helpful, even from an advocacy point of view, to demonstrate these issues, even to the GDG group themselves, in terms of where there might be effects, which are due to there being inequity, for instance. So Tamara, I don't know if we want to ask if there's anybody else who wants to comment on this and see if this is something we can do. You always have limited resources. You can't ask for studies on all of these things. The one thing we always do is effectiveness synthesis, but with the rest, you need to decide, am I going to commission a cost modeling study? Am I going to commission a survey of health program managers to find out if this is acceptable to them? And so I guess this question was, you need to think about whether you're actually going to either interrogate your studies in the effective synthesis to be very clear that each time you're going to ask about equity issues, or are you going to look at it and actually look at some specific studies, or do a qualitative evidence synthesis, for instance.
Thanks, Nandi. I think in the interest of time, I did pop the Progress Plus criteria back into the chat so that people can just have a look across those, because one of the questions I actually wanted to pose was, in the domain of equity, one of the things that might help with operationalizing is looking at which of those factors are most important or most relevant with this question and in our context, because then it might help direct the kinds of evidence that you might want to find. We are reaching the end of the session a little bit. So as I ask, I think, Sumant for a question, I'm going to hand back to Nandi, but I'll happily drive the slides if that will help. So Sumant, over to you.
Yeah, hi, Nandi. In relation to the second question, should home visits compare to no home visits? I was thinking in context of female feticide incidences in India, where the female child is not given the equal amount of care compared to the male child. And it's quite prevalent in the rural areas, and it's quite prevalent in some of the tribals and in the castes. So definitely, I think that they would not encourage home visits if a female child is born, because they, in fact, they really literally they wait for the child to die. So in such situations, the parents or the family members may not encourage home visits or even a visit to the nearest hospital. So I think equity will be applicable in this particular context when I could talk in background of Indian health scenario.
Mm.
I think that's
Yeah.
a brilliant example. And I would then suggest that for this particular guideline, you might want to commission or do a qualitative evidence synthesis of qualitative studies where I'm sure this practice has been researched, and you would then bring those studies into the GDG decision-making forum so that we actually have both. We obviously rely a lot on the observations and the knowledge and the expertise of the GDG, but it would be very good to be able to articulate it clearly that this is a fundamental equity issue, and therefore it will have implications for implementation should you determine to make a recommendation. And I think that's one of the key ways that this can help operationalize the entire guideline process, because it gives you insight into what needs to be thought about to create the necessary supportive enabling environment before you actually implement a recommendation.
Thanks, Nandi. So let's, and thanks, Sumant, for the question. I think we could probably talk about that for a long time still, but Nandi, back to you and just the last few slides.
Yeah, sure. I will
that
finish.
We are 5 to the hour, and so we don't have a lot of time.
Yeah, I'll be very, very brief. I think it's 5 slides. Can you move it forward, Tamara? There we go. So I think as Tamara put the Progress Plus domains into the chat, I looked at some of the other guidelines I've been involved in and really asked whether they're equity domains to prioritize. Now, interestingly enough, in this recently published guideline for non-surgical management of chronic primary low back pain in adults in primary and community care settings, older people were considered as a subgroup and in the equity and the values and preferences domain. And in every single PICO for the effectiveness synthesis, we looked specifically for the subgroup of the older person, and that was in the qualitative syntheses as well. Next one, Tamara. It has not moved ahead.
It has for me.
There we go. There we go. So this is HIV self-testing. And here we thought about gender, location, and occupation. So vulnerable populations, female sex workers, trans individuals, men who have sex with men, injecting drug users, prisoners were prioritized as an equity consideration during the HIV self-testing guidelines. So that was foregrounded and made explicit from the start. Next one, Tamara. So again, just to briefly perhaps loop back to Louis' concern about why you would look at this, it's about what type of studies to conduct when you're thinking about equity. So you could do an evidence synthesis of qualitative studies. This would then require a grade circle evaluation before you bring it to the GDG. You might want to commission qualitative studies of focus groups, surveys, key informant interviews, perhaps thinking about in the Indian context, which was raised. Or you might want to include equity measurement as critical outcomes in the effectiveness synthesis, as well as, of course, the GDG experience, observation, and knowledge base. So we're not discounting that, but we're saying in addition to that, we could perhaps consider, if we want to prioritize equity and help use it to inform implementation, these other types of evidence. Next one. There we go. And then I heard quite a lot in the discussion and in the chat about, we often don't have this type of information. What do we do with it? And I just want to circle back to the fact that guideline development is a cyclical process. And that one of the key things a guideline group can do is actually determine the future research gaps. Say, where are we missing the information that made it very difficult to make a recommendation or not make one at all? And what should we be looking at? And it's here where in the self-care guideline, the GDG actually said, well, there are no outcomes about human rights and equity in the trials. We want them. We want future trials, future studies to actually consider as part of a core outcome data set, outcomes based in human rights and equity. Next one. Mm. And I think this is the final 1 or 2 slides. And I'll post the links in the chat. That's just a reminder of the ecosystem that we're working in. Next one. And then just to think about the lens that we use. This is work I did about gender equity and human rights, particularly in the self-care space for women, around actually once you've made recommendations, and this is using the GRADE framework, there are other ways to look at what outcomes and future research you want. And this was when we put on a gender equity and human rights lens each time, looking at our recommendations, seeing if they were strong or conditional, or if there was no recommendation, and then asking what is the research gap and what should those studies look like? And the final slide, Tamara, I think is, I'll just leave it at that to, if you get to the next one, this is probably a little bit small, but you can actually see in the guideline space, you can even go as far as articulating what the future research study should look like. And I think that if you look at the equality and non-discrimination one, it really gives you a sense that you can, as a GDG member, start driving the research agenda and towards a more equitable focus. So I'll leave it at there, Tamara, and I'll just pop into the chat the links for those 2 studies.
Thanks, Nandi. Thank you so much, Nandi, for that overview. Thanks, Omar, for also introducing us to the health equity concepts and what's out there. I think we will share the slides with everyone afterwards. I'm not going to try and summarize the rich discussion that we've had and the information we've shared, but clearly this isn't a black and white area. This is an area that requires nuance, requires consideration, but always requires consideration in every guideline process and every health decision. So I'm really grateful for the colleagues, and especially Louis, Arthur, Isa, thank you so much again for your extra inputs there. So I will, with thanks, hand back to Idris to close the session. But thanks, everyone.
Yes, I'll join Tamara to say thank you as well. It was quite interesting to hear all of you and know you well, we've met Omar. This is the second time. Thank you so much for a brilliant presentation, Isa, Louis, Arthur, Nandi. Yeah, so just a reminder on the chat, we want to remind the GDG members and steering group members to fill in the survey, capacity needs development survey. Please, it's on the chat right now, and we also have a 5-minute survey for today's session. These are 2 different surveys. The one is 5 minutes for today's session, and the other one is the midterm capacity needs survey. I'm sure all the GDG members and steering group members, you already know about that. And there is also the link for the WhatsApp group. If you want to join, please, you can just click on that link and you'll be added to the group. Thank you so much, and looking forward for the next COP session.
Thank you, Idris. Thanks, everyone. Take care.
Goodbye, everybody.
Have a great evening. Thank you, Nandi. Thanks, Omar.
Thank you.
Thanks, everyone.
Cheers. Thanks. Take
Very
care.
interesting.
Chat again soon. Bye for now.
Bye for now.